So, today we're going to dive deep into the evidence-based principles of surgical antibiotic prophylaxis. And right off the bat, let's be clear, this is so much more than just a simple preoperative task. It's really a sophisticated use of pharmacology and microbiology, all designed to protect the patient when they are at their most vulnerable. I think this statement really gets to the heart of it. It beautifully reframes the whole practice. We're not just talking about a single shot. We're talking about creating and managing a continuous physiological state. The goal isn't just to get the drug in, it's to maintain those bactericidal tissue levels for the entire duration of the surgery. So here's our game plan. We'll start with the basics, the why behind it all. Then we'll get into the core pharmacology. From there, we'll see how it's applied in the clinic, test our knowledge with some case studies, and then we'll wrap it all up with a look at the challenges ahead. Okay, so to really understand how to prevent something, we first have to clearly define what it is we're fighting against. And in this case, that's the surgical site infection, or SSI. So what exactly is an SSI? Well, the CDC defines it as a whole spectrum of infections, and they're all classified by how deep they go. You've got your superficial infections, which are just skin and subcutaneous tissue. Then you have deep incisional, which get down to the fascia and muscle. And then the most serious, the organ or space SSIs right inside the operative field. This classification is absolutely critical, not just for treatment, but for tracking and improving care. And this chart makes a really crucial point crystal clear. SSI risk is not random. It's directly tied to how much microbial contamination is present at the surgical site. You can see the risk just skyrockets from less than 2% for clean wounds all the way up to around 40% for cases that are already dirty or infected. It really shows you how powerful this wound classification system is for predicting risk. And if we dig into the system a little more, you can see just how useful it is. For a Class 1 clean wound, like a hernia repair, you're mainly worried about skin bugs, like Staphylococcus aureus. But contrast that with a Class 2 clean contaminated wound, say a colon resection. Now you also have to worry about gram-negatives and anaerobes from the gut. So you see, the classification system gives us the exact framework we need to choose the right antibiotic from the get-go. So with that foundation in place, we can now get to the intellectual core of prophylaxis, the three pharmacological pillars that really determine if it's going to work. And those are timing, duration, and selection. Central to all of this is a concept called the decisive interval. Research has shown very clearly that for this to work, you have to get those bactericidal concentrations in the tissue before any bacteria show up. The standard rule is to finish the infusion within 60 minutes of the first incision, but the modern view takes it a step further. You have to maintain those levels all the way until the wound is closed. You know, historically, it was common to continue antibiotics for days after surgery, but we now have overwhelming evidence showing that this practice offers zero additional benefit. In fact, it does significant harm by driving antimicrobial resistance and increasing the risk of things like C. difficile colitis. For most surgeries, a single preoperative dose is enough. This shift has been a huge win for antimicrobial stewardship. So why Cefazolin? Why is it the absolute workhorse for surgical prophylaxis? Well, it just checks all the boxes. Its spectrum is perfectly targeted to the common skin flora you see in clean procedures. It has a great safety profile. Its pharmacokinetics are ideal for the OR. And on top of all that, it's inexpensive. It's pretty much the model agent for this job. Okay, so we've got the theory down. Now let's talk about execution. How does all this doctrine actually get put into practice in the operating room? Let's get into the tactical details. Prophylaxis is not a set it and forget it kind of thing. It has to be managed dynamically during the operation. And there are two main triggers you have to watch for it that tell you it's time to redose. The first is time-based. If the surgery goes on longer than 2 half-lives of the drug, you need another dose. The second is volume-based. If there's major blood loss, we're talking over 1,500 ml, the antibiotic gets diluted out, and you'll need a redose to get back to therapeutic levels. And this table gives you the hard numbers. For our workhorse, Cefazolin, the redosing interval is 4 hours. Now, here's the critical part, and a common place for errors. That 4-hour clock starts at the time of administration, not the time of incision. That requires really tight coordination between the surgical and anesthesia teams to get it right. It is so important to remember that the antibiotic is not working in a vacuum. Its effectiveness depends on everything else going on. Prophylaxis is just one part of a system, often called a surgical care bundle. Things like keeping the patient warm, controlling their blood sugar, optimizing oxygen, and using the right skin prep, all of these create an environment that's hostile to infection and makes the antibiotic that much more effective. All right, we've covered the core principles. Now it's time to apply them. Let's work through a didactic module and analyze a couple of realistic clinical scenarios. Okay, case number 1. We've got a few things to consider here. First, the patient's obesity, which is definitely going to affect drug dosing. Second, he's a known MRSA carrier, a major resistant pathogen. And third, he has a reported penicillin allergy, which we need to investigate carefully. So the question for you is, how do you take all these data points, the weight, the microbial threat, the allergy history, and put them all together to design the optimal prophylactic regimen? The best approach here is dual prophylaxis. First, for the Cefazolin, we need a weight-adjusted dose, 3 grams because of his obesity. And since his reported allergy was just a rash, not anaphylaxis, the cross-reactivity risk is very low, making Cefazolin a safe choice. Second, we need to add vancomycin to cover for his known MRSA. And finally, timing is everything. The vancomycin needs a longer infusion, so that should start 60 to 120 minutes before incision, while the Cefazolin goes in within that standard 60-minute window. Now, for a second case, the challenges are all intraoperative. We have a very long procedure and significant blood loss. Both of these things are threatening to drop those antibiotic concentrations right through the floor. Okay, so applying our principles of intraoperative management, you have to ask, was redosing of Cefazolin required here? And if so, what were the specific triggers that told you it was time? Absolutely, yes. Redosing was required, and it was based on 2 separate independent triggers. First, the time trigger. The 4-hour interval from the 8 a.m. dose was up at noon. Second, the blood loss trigger. 2 liters of blood loss is well over the 1,500 ml threshold. This case is a perfect example of how prophylaxis is a dynamic process that requires constant vigilance in the OR. All right, in our final section, let's pull all this together, look at some of the key tensions in prophylaxis today, and think about where the field is headed. You know, one of the biggest conflicts in modern prophylaxis is this. On one hand, you have population-level evidence and stewardship guidelines from groups like the CDC, which all say to stop antibiotics when the wound is closed. But on the other hand, in high-stakes fields like cardiac or orthopedic surgery, where an infection can be absolutely catastrophic, there's a culture of risk aversion that often leads to continuing antibiotics for 24 or even 48 hours. Trying to navigate this tension is a major challenge for clinicians on the ground. And this brings us to a final, and I think, critical question for the future. As the crisis of antimicrobial resistance gets worse and starts to take away our best drugs, the focus is going to have to shift. So how will surgical practice itself have to evolve beyond pharmacology to protect our patients? The future of preventing infections will likely depend less on new antibiotics and more on innovations in materials, in surgical technique, and even in how we manage the surgical microbiome itself.